This is a case presentation of a valve-sparing root replacement, an aortic valve repair, and an ascending aortic replacement. The primary surgeon was Dr. Ken Hassler. The patient was a 70-year-old male with a past medical history of hypertension, hyperlipidemia, and type 2 diabetes. He was incidentally found to have a dilated aortic root with moderate AI on a routine echo. On CT scan, the root measured up to 5.8 centimeters. There was moderate AI with preserved ejection fraction on intra-op TE. The patient was placed on bypass with an arterial cannula in zone 2 of the aortic arch and a venous cannula in the right atrium. The aortic annulus measured 29 millimeters, and the geometric heights of the left coronary cusp was 19 millimeters, right 19 millimeters, non-coronary 26 millimeters. The valve was deemed to be repairable. The aortic root was dissected and both coronary buttons were harvested. 6 2-0 Ethibond sutures were placed circumferentially at the level of the basal ring. A 32 millimeter Valsalva graft was brought into the field and the Ethibond sutures were placed. The graft was suspended externally around the aortic root. The commissures were resuspended at the level of the new sinotubular junction. Using a 5-0 proline suture, the aortic annulus was sewn to the graft. A secondary suture line was created, starting at each sinus and finishing at the top of each commissure. After testing the competency of the valve, there was a gap between the left to non-commissure. A left to non-subcommissural annuloplasty was performed with an autologous pericardial pledget. At the center of both the left and the non-cusp, there was some thickening that was shaved with an 11 blade. The right coronary cusp was prolapsing, so a free margin plication was performed with a 6-0 proline and oversewn with a 6-0 proline. After the competency of the valve was again tested and deemed to be adequate, the coronary buttons were anastomosed to the graft. The annulus now measured 26 millimeters, so the sinotubular junction needed to be downsized. A 28 millimeter graft was brought into the field and anastomosed. Postoperative echo revealed trace central regurgitation. Patient was brought to the ICU and extubated within 4 hours. The chest tubes were taken out the morning of post-op day 1, and the patient went home on post-op day 6. Thank you for your attention to this video. Please check out the links below for further content.